In sort of shifting the paradigm, you need to give some background to it. I think a lot of your education probably comes from pharmaceutical reps coming through the door with one paper and telling you this is the best thing you've seen since sliced bread was invented. So I've given you some more background than probably is required, and I might shift through some of that today. I'm very happy for my slides to go out to you so that if you want to have educational meetings, you can use it to use a bit more of the background to introduce some of the concepts. But I might move through some of them a bit more quickly than is ideal just to get through the program today because we've got a lot to talk about. So I'm going to sort of start off with talking about asthma and then come on to COPD later. But just to remind you that asthma, which is really the focus of this particular type of presentation, is a heterogeneous condition. And it's sort of historically been identified as an airway condition which is reversible and associated with bronchial hyperreactivity. But as I've just mentioned in my lead up to this, I mean, people who develop asthma end up developing some fixed airways obstruction, and the degree of reversibility reduces over time. So it's a fairly limited definition, I think. Its prevalence, I think, is who knows, really, because it's mainly based on questionnaire-based surveys, and they're not very accurate. But the economic burden is certainly there, and it's probably now $1 billion a year that we spend in New Zealand on asthma. The diagnosis of asthma, particularly if you're out there at the coalface, is a difficult one. It's based on your assessment of their history. But in fact, if you go out there and take people who have a diagnosis of asthma and go and round them up and look at them more closely, then you find that no matter which country you look at it, and whether it's Australia or England, you'll find that 30 to 50% of asthmatics actually have an alternative diagnosis. We've already discussed the fact that they might have COPD, but a lot of the patients that I see, particularly in my private practice, have actually got a bit of damage to their small airways. And that's the point we're making earlier, is it often happened in early childhood and or as a result of them smoking in childhood or in early adulthood. They may have stopped smoking 20 years ago, but they've been left with some damage which can then cause problems in later life. As you'll find out, it can lead on to bronchiectasis, but the initial damage is often done, or the initial insult is often in the small airways. Some people with hyperventilation get diagnosed as having asthma, and vocal cord dysfunction is a specific entity which is caused by people actually adducting their vocal cords and causing a loud wheeze, which is often misdiagnosed as asthma. And I remember being asked to come urgently to the emergency department on a few occasions to see somebody who had absolutely severe vocal cord dysfunction and no evidence at all of asthma. Reflux, important as well, difficult to identify, and some people with reflux will actually microaspirate, and it's the aspiration that's causing the inflammation in the airway. Invariably, a lot of people with inflammatory lower airways disorders will have upper airways inflammation and an increased risk of getting sinus infection, which if not diagnosed and treated, means that you'll have difficulty diagnosing the lower airway problem. But the management is difficult. The guidelines that we currently use are based on physiological lung function testing in your clinical evaluation. But increasingly, and since about 2000, people have used biological markers to evaluate the airways, and that has given them a much more useful information than has traditionally been obtained from history, clinical evaluation, and lung function. Biomarkers make a huge difference, and that's a definition of a biomarker. I'm not going to go into that in much more detail, but let's just let you know that biomarkers really is the identification of the inflammatory cell. And in the 1980s and 1990s, we used bronchoalveolar lavage or bronchial biopsy. The people that would agree to that were relatives of researchers or medical students who are the most vulnerable people to trial or evaluate. But they're not really, we don't really offer that obviously to our usual asthmatic patients. But in 1998, Freddie Hargraves and the Hamilton, Ontario group developed this concept of induced sputum testing. And that's using hypertonic saline through a nebulizer to get patients to expectorate sputum, and you can then analyze that. Now, that test takes about an hour in the laboratory to look at, and it takes the the technician about another hour or two to look at it closely to identify the cells. So it's actually an expensive test. We offer it, we used to offer that at Counties Manukau, we're sort of occasionally still doing it, but it's in NZRSI, which is a private institute in Auckland, offer that, and that's the only place in New Zealand that's actually got induced sputum done to the degree that it needs to be looked at to satisfy international criteria. The group that evaluated this are looking at bringing out a monoclonal antibody technique, and that'll be like testing your urine. You put a little stick in it, and you'll be able to pick it up, and it'll tell you what's in the sputum, but that's probably about 5 years away. But when it does come, that's going to be available as a bedside test for GPs and for respiratory physicians. Because of the cumbersome nature of sputums, people have wanted to look at a surrogate, and the surrogate that's been looked at most extensively is exhaled nitric oxide, which, as I'll show you, correlates pretty well with eosinophilic inflammation. But we found in 2007 that a blood level of eosinophil level actually was better than this, and I'll show you the data behind that. And we've published, and now 4 other papers have been published to show the same thing. And we think you can, although it hasn't satisfied all of the issues to do with satisfying a good definition of a biomarker, it's sufficient for us to start using blood eosinophil levels. And of course, it's available to you and to us, and we use it all the time now. Sputum induction, this is the technique. Get somebody to breathe through the humidified air, sorry, not the humidified, the hypertonic saline, and then basically it gets spun down and then plated, and then they do the analysis. And when they're doing the analysis, the 2 things they're specifically looking for are whether eosinophils are present or whether neutrophils are present. So if eosinophils are present beyond, say, 1% of the total white cell population, then it means that they've got asthma, which is suboptimally controlled. If they're on inhaled steroids already, then either they need more or they're not taking their inhaled steroid. It could be that despite taking medication, they're getting exposure to something in the environment, and it could be occupational asthma, for example. But also, interestingly, for smoking-related patients, it identifies a group, if they've got eosinophils present, who do well with inhaled steroids or oral steroids. On the other hand, if it's neutrophils, it could be irritants, such as isocyanates can cause irritant thing. If you're a swimmer trying to get into the Olympic Games and the swimming pool's got too much chlorine in it, you can get exposure to chloramine, which causes neutrophilic inflammation. But more usually, it's actually due to infection, and it's due to, and the most frequently, to the colonization of your airways by pathogenic bacteria. So Peter Gibson, who works over in Australia, who I think is one of the leaders in the field, he's probably one of the top 2 or 3 in the world in terms of publishing around this area, identified in people who were referred to his asthma clinic that when they saw them, that about 40% of them at the time of referral had eosinophils that were in increased number in the airway. About 31% had actually very few cells present. 8% had both neutrophils and eosinophils, and about 20% had neutrophils. And we did the same study in our asthma clinic population and got almost identical results to Peter. So that's the sort of breakdown. If you refer somebody into the asthma clinic, that's the sort of breakdown that we're getting currently of patients who turn up for the first time. So what about these porcine granules? That's the group that have got very low inflammatory cells. In my mind, they're either got a wrong diagnosis, and they're either people with hyperventilation or vocal cord dysfunction, or they've got a chronic cough due to postnasal drip. But some of them also are patients who are asthmatics or COPD patients who are actually well controlled. Their inflammation's well controlled at the time you see them. They only become poorly controlled when they have their next viral episode. But the other group, the mixed group, they tend to be an older group. They tend to be asthmatics with lifelong asthma, patients in their 60s, 70s with airways obstruction, or who have COPD with airways obstruction, and they've often got both eosinophils and neutrophils present. They're the most difficult group you can identify in asthma. They're the most difficult to treat from our perspective. They're less responsive to treatment, probably because their immune system's been stimulated at both ends, and the treatments are sort of counterbalancing the effects of each other to a degree. They've got the worst prognosis and the most difficult, as I said, to control. I've shown you the slide, and I just want to reinforce the fact that you can have a diagnosis of atopic asthma, and very, very occasionally, maybe after a viral illness, you could have an infective exacerbation, and it's just neutrophils that you've got, even though you've got an underlying diagnosis of atopic asthma. On the other hand, these people with COPD, 10 or 15% of them will have eosinophils in their airway and will benefit from inhaled steroids. And even the occasional bronchiectasis patient has eosinophils. But more consistently, they'll have neutrophils down there. Neutrophils, in the great majority of these people, is pathogenic bacteria and requires an antibiotic strategy. I won't talk about that. So if you use biomarkers and use induced sputum tests to not only evaluate whether people have asthma or to manage them longitudinally, you end up with much better outcomes than using any protocols or pathways that utilize clinical evaluation using asthma control test, lung function or whatever. It's a much better way of trying to evaluate, one, whether they've got steroid responsive asthma, and then using it longitudinally if you're in a situation where you can use it to manage them, to try and ensure that you're optimizing their control. So what about exhaled nitric oxide? As I said, it correlates pretty well with eosinophils. It's quite expensive. It costs about $85 to do a test. The equipment is not that reliable and needs to be replaced frequently. But there have been a number of studies that do show that it functions reasonably well as a biomarker and does the same sort of things as induced sputum testing, and it's obviously a lot more convenient and easier to use. Problem with it is that...
Sorry, but it's effective if it's not so good with a smoker, is that right?
Yeah, this is the point of this here, is that it's artificially low in smokers. So you might have asthma and have eosinophilic inflammation, but if you happen to be smoking, you'll get a lower level than is expected. Of course, if they're taking inhaled steroids, it may be low as well, but they may still have eosinophilic inflammation. And these other conditions, if present, can suppress it as well. Conversely, on the other hand, you get some people, you get an artificial increase after viral infections, and some people with these other conditions can have an artificially high level. So there's quite a large proportion of false negatives and false positives. And I don't find it particularly useful. It's okay to screen for a patient who's not on inhaled steroids to see whether they've got high levels. But once they've been taking steroids, then it's not a particularly useful test. So we looked at our asthma clinic population, this is back in 2007, to sort of see whether we could find a bedside test that was more available to people who evaluate people in the asthma clinic, or GPs, yourselves, or nurse practitioners, and just see what other things might correlate well. So we initially looked at expired nitric oxide, and we found a ROC curve which was almost identical to 2 or 3 other papers. So that showed us that our induced sputum testing was working well, and we got the same sort of results. We found that the cut point for an expired nitric oxide was about 20. Some people have found 25, but that was to predict eosinophils, increase in the eosinophils in the sputum. What we were surprised to find, however, was that the serum eosinophil level was actually more useful than the expired nitric oxide level. We were surprised by this because certainly the literature hadn't related to this at all. The cut point, interestingly, was 0.35. So if you know the normal level for eosinophil, it's the upper limit of normal is 0.5, and we're talking about people who are high normal. And so having published this, there are now 4 other papers that have shown the same thing. And it's not surprising, I guess, because eosinophils are produced in the bone marrow. They migrate through the blood vessels out into the airway, or of course into the skin or into the nose, but they're going to migrate through the bloodstream. So it's not surprising that we're going to see a correlation between high levels in the airway and high levels in the bloodstream. This is the most recent paper that's been published in 2014, showing what we actually showed, which was that serum eosinophil level, better predictor of sputum eosinophilia than expired nitric oxide. There's been a lot of effort looking at eosinophilic cationic protein and looking at periostin and saying these are the new biomarkers of the future. They're very expensive, and you see actually they're less good than a blood count. So people are not using these any longer, and they're going back to using a straightforward blood count. If you look and talk to the hematologists and say, this is sort of interesting, how do you interpret this? They say, well, when we looked at the normal values for eosinophils and blood counts, of course, we didn't exclude people who are atopic. And if you do that, the normal range is 0 to 0.1. You know, so interesting. Therefore, what we're doing basically is including people who have atopy and who have higher levels of eosinophils. One of the things that I was disgruntled about was our inability to actually identify, using any test, patients who had high levels of neutrophils in their sputum. And at the European Respiratory Society meeting 2 years ago, a Belgian group had used exactly our model, but instead of having 100 patients like we had in total, they had recruited 6,000 patients in total into their study, and they showed exactly the same results as us. And they actually reflected on that and quoted our paper saying, we've gone to all this expense and effort, but we actually haven't shown anything different than what the group at Middlemore had shown. How disappointing. And I said to them, it's really disappointing because you've got 500 patients in your neutrophil group. One would have hoped that you'd be able to identify that group more accurately. They said, no, we couldn't. I said, well, in my usual practice, I have to tell you, the best way of identifying neutrophilic group is actually very low eosinophil levels. So if somebody comes along and they've got symptoms of bronchitis, and their eosinophil level is less than 0.2, almost invariably, when I do induced sputum testing on them subsequently, they've got very low eosinophils. They've got no eosinophils, they've got mainly neutrophils. And so I said, why don't you use eosinophils as a mirror image? And they came back 4 hours later. I actually emailed them subsequently, and they came back, they said, eureka, it's exactly right. Low eosinophils actually is the best predictor of neutrophils in the airway. So the cut point's 0.23. So now I think we can start using this. So if you see somebody who comes along with bronchitis, who's got an eosinophil level of less than 0.23, 0.25, you can be pretty sure that the major inflammatory cell is the neutrophil, and therefore bacterial infection. Conversely, if it's greater than 0.35, you can be sure pretty well that it's eosinophils. And in between is still a grey area, I think.
The comment before about the Fijian Indian and exposure to parasites.
Yeah. I think there's always going to be a false positive. You know, you have to interpret them. You know, I think broadly. What I'd say is that this was in a population. When we analysed the demographics of the patients who were in our study in South Auckland, there was something like 15 different ethnic groups. That's fairly typical for South Auckland, but about 35% of which were Polynesian. So it's held true even despite that. But sure, if you've got somebody who's been exposed to parasites and who might have hookworm or whatever, then it's going to be less reliable, I would say. But you know, I'd say if you're looking at somebody who's got bronchitis and they've got an eosinophil level of greater than 0.3, it's not a bad way of starting and saying it's likely they're going to have eosinophils in their airway. So why is it important to identify whether they've got high or low sputum eosinophils? This study, not done until 2006, I think it was, Obaka, actually shows why. So he looked at 67 patients who came along to their clinic with a diagnosis of asthma, and he found a group who had increased eosinophils in their sputum and a group of 17 who had low eosinophils. At that stage, they didn't really know much about neutrophils, but you can see, in fact, his average neutrophil score is actually above the limit. The 60 is the cutoff point for neutrophils. So half of this group actually had elevated neutrophils. And this group, most of them were low, but he can see he obviously had some who had a mixed picture who weren't going to do so well in the inhaled steroid group. But basically what he did was he gave them inhaled steroids. These were all steroid naive patients. And you can see that with inhaled steroids, even after 4 weeks, dramatic reduction in the eosinophil count in the sputum. But this group already had low eosinophils, low normal, not much difference there, and no change at all in the neutrophils. So steroids don't actually have any effect on neutrophilic inflammation. If anything, they actually make the neutrophilic inflammation worse. You can see neutrophil counts every time you look at induced sputum tests. Even though the eosinophils will go down, the neutrophils actually go up a little bit if they're present. And what did he find clinically? Well, he found that the high eosinophil group got better. Their lung function improved from 87 to 97, but the low sputum eosinophil group, no improvement in lung function, no improvement in symptoms. So that's the important first study, I think, that subsequently led to a number of other studies showing exactly the same thing. That is, that if you've got neutrophilic inflammation, you won't derive any benefit from taking steroids. So I presented this at a meeting called bronchitis meeting in 2006-07, and it was with the top sort of 150 sort of researchers in the field over in Holland. It was where the Dutch hypothesis generated from that meeting historically. It's a fantastic meeting, but people went away and said maybe we've missed the boat with blood tests, and they went away and started looking at it in a whole variety of other ways. And I'm going to share with you some of the data that's come from looking at it in COPD. So this is just to make the point again that eosinophils don't like steroids for a whole variety of reasons. It's the best treatment we've still got for treating eosinophilic inflammation. There's going to be some monoclonal antibodies around that are targeting IgL4 and IgL5 and IgE, which will impact as well. But as a straightforward approach, steroids remain a good treatment. The problem with inhaled steroids, however, if you're using them, is that they've got a flat dose response curve. A lot of the studies that you'll see in the literature who say, well, you'll do better off putting people on long-acting beta-agonists. If you look at the time frames in which they've evaluated the effect of steroids, they've been 12 weeks or less. And if you've got somebody who's got severe eosinophilic inflammation, particularly if it's been present for a long time, they're going to get better quickly if they've been on inhaled steroids for a while already. They're going to take quite a long time before they start to generate improvements in lung function, bronchial reactivity, symptom control. But you don't want to give up on the fact if they've got eosinophilic inflammation, you want to maximize your dose of inhaled steroid, and I'll reflect on that later in another talk. You want to make sure you're giving them a decent and targeted dose of inhaled steroid. And this is just making that point again, is that what treatments that we currently use modify the natural history of asthma. Inhaled steroids do. Long-acting beta-agonists don't. If you started somebody on a long-acting beta-agonist and you stopped it 2 years later, they'd go back to the same lung function they had when you started it, and the degree of bronchial reactivity would re-emerge exactly the same as when you first started it. But if you got them onto a decent dose of inhaled steroids, their lung function will gradually improve and stay improved. Their bronchial reactivity will gradually reduce, and in most instances. Anti-inflammatory effect, yes, no. There's a lot of drug companies saying it, yes in the laboratory, no clinically. Improved lung function, yes over time, yes immediately. Days to therapeutic, could be long time, but you need to share that with the patient so they're aware of what you're trying to achieve. Long-acting beta-agonists currently. So what's happened is that these have come into our treatment strategy a lot more earlier than I think they should do, and internationally people are now looking at moving them back a step, because if you're going to be worried about any medication long term, you should be more worried about the adverse effects of long-acting beta-agonists. So we're now thinking that maybe instead of bringing them in early, maybe bring them a bit later, and particularly after you've maximized your effects of inhaled steroid, and so on. Okay, COPD. We talk about mild to moderate, use SABAs and SAMAs, and then you use long-acting muscarinics like Spiriva, tiotropium, and then your long-acting beta-agonists. But here they go. Here's the international standard. Sorry, it's a bit badly copied. But they're saying once you get to severe, add in inhaled steroids. And where's the benefit from that? The benefit is that there's some weak data that shows that if you add in inhaled steroids in people with severe COPD, you reduce the frequency of their exacerbations. So how's that transferred into practice in New Zealand? 97% of people with a diagnosis of COPD discharged from our hospital are on an inhaled steroid. And in fact, when you actually evaluate them using dispensing data, they're actually pretty compliant with it. The great majority of those patients aren't going to be deriving any benefit from it at all. And in fact, in a GP practice in East Health, where they actually have very, very good standards of care, 70% of their patients with a diagnosis of COPD were on an inhaled steroid. And in fact, there's a recent study coming out of the UK showing 65% of patients with a diagnosis of COPD in the UK are on inhaled steroids. But there's only 10 or 15% who've got eosinophilic inflammation and who will derive benefit. Well, a lot of people say, well, so what? I mean, it's not very targeted, but it won't do them any harm. Well, it does do them harm. This is data from GlaxoSmithKline's TORCH study. These are patients where they didn't use biomarkers to assess whether they should be on inhaled steroids or not, but they all went on to either Seretide or I think Seravent, and they were compared versus salmeterol versus Seretide here. And they followed them over 3 years. And they reported the results at 6 months. And they said at 6 months, you only need to treat 26 patients to reduce the exacerbation rate by 1, but you have to treat 100 before you increase the risk of pneumonia by 1. So there's quite a big therapeutic benefit relative to risk. There's nothing heard from them again in that study until Sami Souza, who's a pharmacoepidemiologist who works at McGill, who I've done some work with. He got hold of the data, and lo and behold, after 3 years, you only have to treat 20 people to get a diagnosis to increase the risk of pneumonia by 1, but you have to treat 43 to reduce the exacerbation rate. So most of the benefits were derived early, but you're getting an increasing risk of bacterial infection. The question is this just related to Flixitide? And there are some theoretical reasons as to why that might be. Or does it relate to the dose of inhaled steroid? I think there's a mixture of both. Here's some data I subsequently went and looked at. Remember back in the 1990s, we used to use Flixitide unprotected without a long-acting beta agonist. We used to use 1 milligram a day. Look at the number of people who were diagnosed with COPD at Middlemore Hospital who ended up with pneumonia. 30% of the patients who came in with a diagnosis were also admitted with a diagnosis of pneumonia in the same year. We've gone away from that. Not a lot of these patients are on Seretide, so they're on half the dose of inhaled steroid. Still getting 19-20% of them getting pneumonia in the year subsequent to their discharge from hospital. And the rate should be about 5 to 8%. People with COPD are increased risk of getting pneumonia. So we're actually increasing people's risk of developing pneumonia. You talk about anecdotes. I've seen 2 patients who were admitted under my team in the last couple of weeks, came in with an effective exacerbation of COPD, went home on a 2-week course, reducing course of prednisone, 5 days of romycin, and they had no eosinophils when they came in, and they came back with pneumonia 3 weeks later. You know, they basically set them up, and they were on Seretide. So they were basically discharged home from a general medical ward, you know, basically setting them up for a much greater risk of developing infection. Why that greater risk? It's because they're colonized with pathogenic bacteria. Even if you treated them with antibiotics, they'll still have some bugs hanging around in their airways. So if you give them an inhaled steroid, particularly a lipophilic one like Flixitide, that hangs around for a long period of time, you're actually adding a bit of fertilizer to the brew of bacteria down there. So people have become increasingly concerned about inhaled steroids, and this is a study which was undertaken by Magnuson, where he just said, let's just get these people off inhaled steroids and see what happens to them. And they didn't use biomarkers. They just took everybody who had COPD and withdrew their glucocorticoids. And they found that there was no increase in exacerbation rate. There's either mild or severe, but there was a small reduction after a period of time in their lung function. So I think that's not surprising, because there's going to be 10 or 15% of these people who will be disadvantaged by having their inhaled steroids removed. But I'm just making the point to you, you can stop them and not get into too much trouble, but I wouldn't do that. I'd do it in a more sophisticated way, but I'm only sharing that with you because it's showing you that people are now thinking about trying to get people off inhaled steroids with COPD. So what we know about COPD is if you've got eosinophils present, then you actually have a more troublesome pattern of COPD, and that eosinophilic presence can actually be determined quite nicely by straightforward blood count. But if you've got eosinophils in your airway, you're more likely to have a more downhill course. You're more likely to have exacerbations, and you're more likely to have exacerbations that are severe and that require hospitalization. So it is important to identify people with eosinophilic inflammation. And in peripheral eosinophil in the blood test, and this has come out as a result of other people's studies looking at it, are actually useful ways, in the same way as they are in asthma, they're useful ways of evaluating patients with COPD. So this is a study I was going to share with you in more detail, and it's where they use blood eosinophils to direct steroid treatment of exacerbations in COPD. What they found was that when they recruited patients, they screened them and they did a blood eosinophil level. And interestingly, the blood eosinophil level that they did when they saw them, for example, in your surgery, actually determined quite accurately what happened to them when they had an attack of bronchitis. They were able to predict from the serum eosinophil level at the time that they recruited them as to what was likely to happen to them at the time they had an attack of bronchitis. And what they did was that they randomized people into a standard arm where they got 30 milligrams of prednisone for 2 weeks, and a biomarker-directed arm where they only got 30 milligrams of prednisone if they had a serum eosinophil level of greater than 0.3. But everyone received antibiotics, either amoxicillin or if they were sensitives to that doxycycline. They actually only received those for 7 days. So they were, I think, trying their best to show an adverse effect from using steroids, but they used the blood eosinophil level to direct their approach. And what do they find? Well, if you had a eosinophil level of less than 0.3, and who were given placebo rather than prednisone, they did better. And they had a better symptom score at 2 weeks, which was statistically significant. If they received steroids and their serum eosinophil level was less than 0.3, that was in the usual care group, they actually ended up with a worse outcome. There were 15% had a treatment failure versus only 2% in the less than eosinophil level of 0.3. And so they had more treatment failures when they gave them steroids. And there was a higher proportion who had no improvement in symptoms even after that 7-day marker if they had an eosinophil level of less than 0.3 and were given prednisone. So interesting result. And I've shared that with you in more details so that you can look at that. So what's happening currently, even now despite me talking about it, 90% of people coming into Middlemore Hospital are still on steroids. I take people off steroids when I go around my ward rounds, and I haven't seen anybody deteriorate as a result of coming off steroids if they've got an eosinophil level of less than 0.3. If you actually look at their eosinophil level, I had to look at it and said they don't actually have any eosinophils in their blood count at all. And I rang the hematologist and said, do you not report eosinophils, and they get to a low level? And they said, no, we can't find any in that group. So they don't even have any eosinophils. So you're treating them with steroids, but not actually, they're not deriving any benefit. In fact, you're reducing the efficacy of the antibiotics by doing so. So the summary of my talk is that use the serum eosinophil. There will be some false positives and false negatives, but generally if you've got somebody in front of you who's got symptoms of inflammation in their airway, whether they be asthma, bronchiectasis or COPD, if their eosinophil level is less than 0.25 based on our tests, then it's an antibiotic strategy. Conversely, if it's above 0.35, it's a pretty good chance they've got eosinophils. Use your inhaled steroids, or in an attack of bronchitis, you can use some oral prednisone. And in this group here, I think we have to stay, it's a bit of a grey zone. My feeling is that most of these people in this area probably have a mixed inflammatory airways disorder. So I think there's nothing wrong with giving a bit of steroid in that group as well, but I'd be very wary otherwise. So thanks very much.